Good morning. For rounds today, I'm presenting the case of Renata. We're going to be exploring the actual mechanisms of gallstone formation, how we distinguish true biliary pain for just functional dyspepsia, and finally, defending our clinical decision to operate. My goal today is to walk you through exactly why this specific gallbladder needs to come out while breaking down the underlying pathophysiology that brought her to our medicine service in the first place.
To keep things structured, our presentation is going to follow 4 acts. Act 1 is the admission presentation. Act 2 is our pathophysiology deep dive. Act 3 covers our assessment, plan, and ward management. And Act 4 will wrap up with her disposition and some high-yield teaching pearls.
All right, Act 1, the admission presentation. Let's dive right into our patient, Renata. She's a 44-year-old 4th-grade teacher, and she presented to us after having 2 discrete, pretty brutal attacks of severe upper abdominal pain over just the last 6 weeks. Also, super important context here. She has lost 32 pounds in the past 5 months after her PCP started her on a GLP-1 receptor agonist. Now, urgent care saw her during her very first attack. They basically anchored on her symptoms, called it gastritis, and threw her on a daily proton pump inhibitor. So our job right out of the gate is to figure out if this pain is actually coming from her stomach or if it's coming from her biliary tree. To figure that out, we really have to look closely at the attack itself. It started abruptly at 10 p.m., notably about an hour after she ate a meal of fried chicken. The pain was primarily epigastric, actually more so than right upper quadrant, and it was steady and severe. She specifically told us that absolutely no physical position brought her any relief, and, physiologically, this makes total sense. At this early stage of biliary disease, we're dealing with pure visceral pain. Visceral pain comes from stretching and distending a hollow organ, in this case her gallbladder contracting against an obstructed cystic duct. Because it's visceral, it's diffuse, it's poorly localized, and it is completely unaffected by movement. It's totally different from the somatic, well-localized pain of peritoneal irritation that makes a patient lie perfectly still in bed. Her pain radiated straight through to her right shoulder blade, she had some nausea and 1 episode of vomiting. And then the whole thing completely faded away in about 2.5 hours. Urgent care saw the epigastric location, assumed acid-related gastritis, and handed her a PPI. But the absolute critical point here, that PPI did absolutely nothing for her symptoms.
Moving to her background and exam. Renata has a history of obesity and dyslipidemia, and she recently started a statin for that. She's had 2 pregnancies, used oral contraceptives back in her 30s, and of course there's that rapid 32-pound weight loss on the GLP-1 agonist. She also has a very strong family history. Her mom actually had a cholecystectomy at age 45. On exam today, she is completely well between these attacks. She's afebrile, vitals are totally normal with a heart rate of 78 and blood pressure of 128/76. Her abdomen is soft, just some very mild epigastric tenderness. No guarding, no jaundice, and importantly, a completely negative Murphy sign. Now let me just pause on that negative Murphy sign for a second. In patients with a higher BMI, trying to elicit a true Murphy sign can be anatomically pretty challenging, just due to body habitus. So we can't look at a negative Murphy sign in isolation, we have to look at the objective data. And her data is pristine. Her white count, AST, ALT, ALK phos, bilirubin, and lipase are all perfectly normal. As we build our differential, these completely normal labs are honestly the linchpin of our entire workup.
Before we get too far into the weeds with her case, we need to get our terminology straight. These 3 words get thrown around and confused constantly on the wards, but their anatomical distinctions literally dictate our entire management plan. Cholelithiasis refers strictly to stones just sitting inside the gallbladder itself. Cholecystitis means the gallbladder wall is actively inflamed, usually because a stone got permanently wedged in that narrow cystic duct. And choledocholithiasis means a stone has traveled further down, exited the cystic duct, and entered the much wider common bile duct, which can back up the entire liver. Cholecystitis and choledocholithiasis are major, severe complications. Today's case focuses entirely on uncomplicated, symptomatic cholelithiasis. We're talking about stones sitting in the gallbladder before any infection or ductal obstruction has occurred.
All right, moving into Act 2, the pathophysiology deep dive. To understand why Renata is having these attacks right now, we can't just treat her pain. We have to look at the underlying mechanics. Understanding this is essential, especially given her current medication regimen. A gallstone doesn't just magically appear overnight. It actually forms through what we call the 3 hits of stone formation, and they all have to happen simultaneously. Think of bile as a fundamental solubility problem. Your liver secretes bile salts, phospholipids, and cholesterol.
Now, cholesterol is highly hydrophobic. It absolutely does not dissolve in water. So the amphipathic bile salts and phospholipids act as a team, forming micelles to hold that cholesterol in a very delicate liquid solution. If you tip that delicate ratio, bam, you get the first hit, supersaturation. Cholesterol levels rise right past the capacity of what those bile salts can actually hold. Then comes the second hit, accelerated nucleation. Those unsupported cholesterol molecules precipitate out into solid microscopic crystals, and they grow abnormally fast. But honestly, even those two aren't enough on their own. The third hit is hypomotility. If a gallbladder empties normally, it just flushes those microscopic crystals right out into the duodenum. But in a sluggish, hypomotile gallbladder, the bile stagnates. And when bile stagnates, the gallbladder mucosa responds by secreting excess mucin. This mucin forms a highly viscous gel that acts literally like cement. It physically traps those nucleated cholesterol crystals, letting them aggregate and fuse over months to years into a true solid stone. You really need all three of these hits working together.
We can basically categorize all clinical risk factors right into these mechanistic buckets: SAT, slow, and salts. SAT means more cholesterol is being pushed into the bile. This is driven by things like obesity, dyslipidemia, estrogen, OCPs, and clofibrate. Slow means the gallbladder just isn't emptying well, driven by rapid weight loss, total parenteral nutrition, pregnancy, and drugs like octreotide. Salts refers to having fewer bile salts returning from the terminal ileum to dissolve the cholesterol, which is what happens in isle disease. So let's apply this directly to Renata. She carries several fixed risks for gallstones. She's female, over 40, and has a history of pregnancy. We also have to note that folks of South, Central, and Native American ancestry carry significantly higher fixed genetic risks, which just emphasizes why we need a thorough demographic history. But her medications? They are the primary drivers here. Her rapid 32-pound weight loss on that GLP-1 agonist hits two of our mechanistic buckets at the exact same time. It increases cholesterol saturation into the bile as adipose tissue rapidly breaks down, and GLP-1 agonists inherently slow down both gastric and biliary emptying, which promotes severe hypomotility. On the flip side, her statin is actually lowering her risk. Statins upregulate hepatic LDL receptors, pulling cholesterol from the blood into the liver, which paradoxically decreases biliary cholesterol secretion. That means fewer symptomatic stones and fewer cholecystectomies overall for statin users. But in Renata's case, her other risk factors clearly heavily outweighed that protective benefit.
So once a stone forms, what is it actually made of? Well, in Western populations, 90% of gallstones are cholesterol-based. This is a direct result of those supersaturation mechanisms we just broke down. We consider them cholesterol stones if they're pure cholesterol, or mixed stones that contain over 50% cholesterol. They usually look yellow-white and are heavily tied to obesity, estrogen, and rapid weight loss. The other 10%? Those are pigment stones, and they come from entirely different pathophysiological pathways. Black pigment stones are made of unconjugated bilirubin. You'll see these forming in settings of chronic hemolysis, like sickle cell disease, or in cirrhosis, cystic fibrosis, and Gilbert syndrome. Then you have brown pigment stones, made of deconjugated bilirubin. Interestingly, these form predominantly in the bile ducts themselves rather than the gallbladder, usually driven by biliary stasis and bacterial infection that enzymatically deconjugates the bilirubin. Based on her profile, Renata squarely belongs in that 90% cholesterol stone category. To really grasp the clinical picture here, you have to look at the natural history, and specifically this 80% figure. Check this out. Approximately 10% of Western populations carry gallstones, but a staggering 80% of those people will stay entirely asymptomatic their entire lives. They'll never even know they have them unless they're found accidentally on a scan ordered for something else entirely. We leave quiet stones alone because prophylactic surgery just can't beat that natural history. Now, of the silent stones, about 15 to 25% of these patients will become symptomatic over a 10 to 15-year period. So generally, only 1 to 4% of people per year make that transition from silent to having symptomatic biliary pain. But, and this is the big but, once those symptoms actually start, the complication rate suddenly climbs to 1 to 3% per year. Symptoms are the critical switch that tells us it's time for surgical intervention.
Which brings us nicely to Act 3, Assessment, Plan, and Ward Management.
When Renata hit urgent care, they diagnosed her with gastritis or dyspepsia and handed her a PPI. We need to completely, firmly defend the diagnosis of biliary pain over dyspepsia right here, right now. Dyspepsia presents as a daily or near-daily burning, bloating, belching, and early satiety. There are no completely pain-free weeks, and the symptoms generally ease up with antacids or a PPI. But Renata's presentation is literally the exact opposite of that. Biliary pain is about discrete, episodic attacks with completely well intervals in between. The pain starts abruptly, it's severe enough to totally derail her day, and it lasts roughly 30 minutes to 3 hours. And notoriously, it radiates right through to the right scapula. This is such a classic example of referred pain. The visceral afferent nerve fibers from the gallbladder actually share neuronal pathways with the somatic afferents from the C3, C4, and C5 spinal nerve roots via the phrenic nerve. So when the gallbladder is intensely distended, the brain gets confused. It misinterprets that visceral signal as coming from the somatic distribution of the right shoulder and scapula. Also, real quick somatic point. You'll often hear people say biliary colic. Honestly, it's a terrible misnomer. Colic implies pain that comes and goes in waves, like what you'd see in a bowel obstruction. Biliary pain is steady and continuous. Renata's discrete, abrupt, steady attacks radiating to the scapula, specifically triggered by fatty fried chicken, perfectly match biliary pain. That is exactly why her daily PPI didn't do a single thing.
Okay, so once we establish this is biliary pain, we have to separate uncomplicated cholelithiasis from all the scary competing complications. And we do this entirely with her vitals and labs. Acute cholecystitis? That requires systemic signs of inflammation. We're talking fever, a positive Murphy sign, or leukocytosis, and the pain usually lasts well past a few hours. Cholelithiasis, a stone in the common duct, would give us a rising bilirubin or alkaline phosphatase. Ascending cholangitis, that adds severe infection right behind that ductal obstruction. Gallstone pancreatitis, we'd absolutely see a high lipase. But look at Renata. She is afebrile, soft abdomen, perfectly normal liver enzymes, a totally normal white count, and a pristine lipase of 30. Because she has none of these markers, we have successfully and confidently ruled out every major complication. We have safely isolated this as uncomplicated symptomatic cholelithiasis.
Now, to confirm the anatomy, our gold standard imaging is a right upper quadrant ultrasound performed after a minimum 8-hour fast. Fasting is absolutely critical here. It ensures the gallbladder is fully distended and filled with bile, which gives us the necessary acoustic window so those stones really stand out. When it's done correctly, an ultrasound boasts over 95% sensitivity and specificity for stones larger than 5 millimeters. Now, if an ultrasound is normal, but your clinical suspicion for biliary pain is still super high, your next step is an endoscopic ultrasound. That pushes sensitivity way up to 94 to 98%. I really want to emphasize a major clinical pitfall for the wards here. A CT scan is absolutely not the test of choice. Pure cholesterol stones have Hounsfield units that are nearly identical to the surrounding liquid bile. That makes them completely isodense and literally invisible on a non-contrast CT scan. You need calcium within the stone for it to even show up on a CT. So remember, a negative CT scan never, ever rules out gallstones.
So we went ahead and ordered the fasting ultrasound for Renata, and it showed classic findings: multiple mobile echogenic foci casting an acoustic shadow, with the largest one measuring about 9 millimeters. Crucially, the gallbladder wall thickness is totally normal at 2 millimeters, there's zero pericholistic fluid, and the common bile duct is a normal 4 millimeters. This imaging perfectly aligns with everything in our clinical and biochemical assessment. The stones are there, but there is no acute inflammation and absolutely no ductal dilation. Our plan, then, is super straightforward. Because symptomatic stones carry such a high risk of progression, again, 20% of patients with symptomatic biliary pain will progress to acute cholecystitis within 2 years, we are going to proceed with an elective laparoscopic cholecystectomy. Once symptoms start, sooner is always better to prevent those complications. While she's waiting for surgery, we'll manage any breakthrough attacks with NSAIDs. NSAIDs, like IV ketorolac, actually have efficacy that's roughly equal to opioids for biliary pain. And this is vital. Opioids like morphine can actually cause the sphincter of Oddi to spasm. That spasm paradoxically spikes biliary pressure and can severely exacerbate a patient's pain. So NSAIDs are absolutely the superior choice here to avoid raising that sphincter pressure.
To be clear, we are operating on Renata because her severe symptoms drive the indication for the operation. Like we said, the general rule is you leave quiet, asymptomatic stones alone. However, just for completeness on rounds, there are exactly 6 rare exceptions where we do advocate operating on purely asymptomatic, quiet stones. We operate if there's a porcelain, heavily calcified gallbladder wall because that carries an elevated cancer risk. We operate if there are gallbladder polyps larger than 10 millimeters, or if the stones themselves are just massively large, over 3 centimeters. We also preemptively remove the gallbladder in bariatric surgery candidates and cardiac transplant candidates where the post-transplant immunosuppression would fatally mask a future cholecystitis, and in patients with chronic hemolytic anemias like sickle cell disease who are just constantly generating those black pigment stones. In any other scenario, if there are no symptoms, you leave the stones alone, period.
Finally, let's wrap up with Act 4, Disposition and Teaching Pearls.
So what if Renata was a terrible surgical candidate? Well, we could prescribe ursodeoxycholic acid, or UDCA. It actually acts to dissolve cholesterol stones, and it notably lowers the stone risk associated with rapid weight loss. But there's a catch. It takes about 3 months to work, so it's utterly useless for acute symptom relief for us tonight. For severe cases with unacceptably high operative risk, we'd have to look at percutaneous drainage or endoscopic transpapillary drainage just to decompress the system. We also need to stay super vigilant for the rare 1% complications of gallstone disease. You only catch these if you actually think of them. Things like Maritzi syndrome, where a huge stone stuck in the cystic duct physically compresses the adjacent common hepatic duct, causing external biliary obstruction and jaundice. There's also the risk of a cholecystoenteric fistula. Chronic inflammation causes a stone to erode straight through the gallbladder wall into the duodenum. And that can lead to gallstone ileus, where that large stone travels down the GI tract and physically obstructs the bowel, usually right at the narrowest point, the ileocecal valve. Lastly, there's gallbladder carcinoma, which is rare but unfortunately often found very late.
Before we send her out, let's quickly review the clinical pitfalls. These are the classic cognitive errors we've got to watch out for on the medicine service. Number 1. Never ever dismiss steady, severe, episodic epigastric pain as mere dyspepsia. That's the exact trap the urgent care fell right into. Number 2, making the fatal error of trying to rule out gallstones with a CT scan. Remember, CT completely misses stones without calcium. Number 3, ordering an ultrasound on a patient who just ate lunch. Their gallbladder will be totally contracted and the stones will be completely hidden. Number 4, finding an incidental quiet gallstone and incorrectly blaming it for a patient's chronic, daily bloating and belching. Taking that gallbladder out is not going to fix their functional symptoms. And finally, operating on quiet stones without meeting one of those strict indications we just talked about.
So for Renata's actual disposition, she's feeling well today, so we don't need an emergent surgical consult. Instead, we'll refer her to general surgery as an outpatient from the clinic while she's currently in her well interval. We're going to provide her with NSAIDs for any breakthrough attacks, and we are absolutely stopping that useless daily PPI. We'll also do some thorough counseling on her GLP-1 agonists. We won't necessarily stop the medication today, but we absolutely need to counsel her on the speed of her weight loss. We'll coordinate with her PCP to potentially adjust her titration schedule to help mitigate any further rapid shifts in biliary stasis. Most importantly, we are giving her very strict return precautions. She needs to know to come back to the ED immediately if she gets a fever, new jaundice, or if her typical attack pain just keeps going past a few hours, because that would signal she's progressing to cholecystitis or cholelithiasis.
As we wrap up rounds on this case, I want to leave you with this final thought. We know that 10% of the population carries these silent stones, right? And 80% of them will literally never have an issue. The real art of medicine here isn't just finding a stone on an image. It's recognizing that exact abrupt moment when the clinical switch flips from silent carriage to true biliary pain. Can you spot that specific, steady epigastric pain before the fever, jaundice, or pancreatitis sets in? Because recognizing that switch is the absolute key to preventing disaster and getting the patient to the operating room safely. Thanks for your time on Rounds today.